the FDA approval for the combination comes from the data from the phase 3 Checkmate 214 study. So in that study, patients received their Ipilimumab every 3 weeks for 4 doses. So hence that represents the current standard schedule. So if you look at the data we had before the phase 3 study, well, there was some exploration of dose of these drugs. So there was a phase 1 Checkmate 016 study that looked at the dosing. So you could either have IP3 Nivo 1, that's milligrams per kilogram of drug, so IP3 Nivo 1 or IP1 Nivo 3. So we saw from that efficacy looked about the same with those 2 dosing strategies, but the toxicity looked favorable for the lower dose of Ipi, hence that was taken forward to the phase 3 study. But actually, we hadn't seen any data looking at the scheduling of these drugs in kidney cancer. There was some data in lung cancer. So in non-small cell lung cancer, there was some early phase data that included cohorts that had 6-weekly and 12-weekly dosing of the Ipi. And that gave us a strong hint that looked like it might be better tolerated than the standard 3-weekly dosing. And we've since seen similar data now emerging in melanoma as well. So basically, there was this growing interest in and recognition, really, that probably the way that we're giving these drugs was suboptimal, and there was opportunity to improve the risk-benefit ratio for patients, and hence really that was the rationale for the PRISM study. So perhaps the first thing to say is that when we sat down to design PRISM, the results of the Checkmate 214 study weren't yet available. So you'll see things like the fact that we included favorable risk patients in the study, and we actually had a comparison to historical sunitinib treated patients. So it's worth just perhaps clarifying that. But in terms of the specific design, well, of course, the hypothesis was around safety. The hypothesis was that modified scheduling would lead to a favorable toxicity profile. But of course, we had to show at the same time that we weren't compromising efficacy clearly. Now, to formally do that, of course, would have required a large phase 3 non-inferiority study, and we didn't feel that was the right way to go. We wanted to take a more pragmatic approach. And so we took a perhaps rather unusual step for a phase 2 study where we made safety the primary endpoint. Efficacy actually formed it was a key secondary endpoint that we were going to test in a hierarchical manner. So, but the idea was that the efficacy in the standard arm would allow us to compare the activity in PRISM against other trials, in particular, of course, thinking about Checkmate 214, and of course allow us to informally compare the efficacy with the experimental arm of the study. So a slightly unusual design in that sense, as I say, given it was a safety primary, but actually, we think that this sort of design is likely to become more commonplace, given this emphasis around dose and schedule optimization of cancer drugs in oncology. So if we remember back to Checkmate 214, there we saw in that study that almost half of patients, about 47% of patients, experienced a grade 3 or 4 treatment-related adverse event, and we've seen a similar sort of figure in the control arm of Cosmic 313. And so then, if we look at the control arm of PRISM, actually again it compares very well. It was slightly higher at 53% of patients with a grade 3 to 5 toxicity. So in that context, then, that in the modified arm, we saw a significantly lower rate of high-grade toxicity at 33%. And if you look, well, and we think it's important to say, I think it's not just statistically significant, we think that's a clinically relevant reduction. And if you look at some of the specifics around that, then it's things like high-grade arthralgia, colitis, hyperphysitis, that were lower in the experimental arm of the study. And that, you know, that data is in a way backed up by what we saw in terms of treatment discontinuation rates, again, which were lower with modified scheduling of Ipi. So, you know, overall, we can certainly say that the data support the hypothesis that less frequent dosing of Ipilimumab leads to a more favorable toxicity profile. And, you know, as we've said, this really is in line with some of the data that's also emerging from other tumor types. So really, overall, they compare very well. We really couldn't detect any meaningful difference in terms of response rates, PFS, or OS. Now, of course, it's important to keep saying that we couldn't formally compare the two arms for efficacy, but we certainly, in terms of OS, we had a median follow-up approaching almost 3 years, and as I say, we didn't detect any meaningful reduction in efficacy. And then if you compare that efficacy with what we saw in Checkmate 214, again, it compares really pretty well. An overall response rate of 40% is pretty much what we saw in the phase 3 study. In terms of PFS, well, the number it was numerically a bit lower, but it still sat within the 95% confidence interval of Checkmate 214, and similar with some of the landmark OS analyses as well. In fact, the only difference was the CR rate, the complete response rate, which was lower in PRISM compared to the phase 3 study. And we think that that's probably because of the lower nephrectomy rate in PRISM, and in fact we've seen a similar thing in Cosmic 313 that also had a similarly low rate of nephrectomy. I think the overall take home here is that I think the timing of the Ipi in this combination probably isn't critical. So I think what it does, if nothing else, at the very least, it should give clinicians some reassurance that if they want to delay the Ipi for whatever reason, and in particularly we think about allowing time for a toxicity to settle, or it might just be to just watch a patient for a bit longer before going in with that next dose of Ipi. Hopefully these data, as I say, at the very least, give us the reassurance that that shouldn't be detrimental and to the patient in terms of the efficacy of these drugs. But, you know, perhaps I think we could go a bit further and suggest that perhaps that giving the Ipi in a modified way and in a planned way is not an unreasonable approach based on the data that we've seen here. And, you know, thinking in particular about patients where we might be more concerned about toxicity, and thinking particularly about patients, for instance, with pre-existing autoimmune disease. So overall, I'd say, you know, we know that getting that first dose of Ipi in is clearly important. We've seen that, and trying to use it later on as a rescue strategy isn't robust. But once that first dose has gone in, it does seem that the timing of subsequent doses isn't critical. the first thing to say is that PRISM was a large, almost 200 patient randomized phase 2 study. So I think the data in their own right are pretty compelling. I guess the question is whether we should now go on and do a confirmatory study. As we've said, that would need a large study powered for non-inferiority. And we think that is difficult to justify that, and given the resources that would need, and as I say, the results that we've already generated. What I would say is that, though, perhaps that there are future opportunities to employ a modified schedule. I'm thinking in particular, future triplet studies, such as we've seen with Cosmic 313, where clearly mitigating the toxicity of the combination is important when you're trying to add in a third agent. And then I think the other point to make here is that there are so many other questions to ask around this combination, and that includes other ways of trying to modify the way that they're given. So, for instance, in the UK, there is currently a study called REFINE, which is looking at also looking at the timing of the way these drugs are given. But in this case, in the renal cohort of that study, the question is around not the induction phase, but the maintenance phase, and a question there around the timing of the Nivolumab, and do we really need to give it every 4 weeks? And there's actually pretty sound rationale to suggest that isn't necessary. So that study is randomizing patients to either 4-weekly or 8-weekly Nivolumab. And then there are other questions, as I say, that are also important in regards to this combination, thinking about whether we can stop these drugs. That is clearly a key question. Can we stop them? And if so, when is it safe to do so? And then ultimately, actually, who we should be actually treating in the first place. Can we identify non-responders versus responders?